Yeah. I think I should say good morning, Dr. Carlos Morales, and good evening, everyone. Welcome to Medical Family Mandalay Tele-Education Program. It is our pleasure to host such a special CME. Today, we are presenting diagnosis and management of heart attack in places without a cath lab, presented by Dr. Carlos Morales. We believe this topic will be one of the most interesting topics during our revolution time, and that might help a lot in treating our patients. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the question box on your Zoom control panel. I will bring it up during the presentation, and we'll also have time for questions at the end. First of all, I just want to introduce just a little bit about Dr. Carlos Morales. He's one of the famous cardiologists in the United States of America. He received his medical degree from University de El Salvador Faculty of Medicine. He's a chief cardiologist in Doctors Hospital of Renaissance. He's also a director of cath lab, and he's been in practice for more than 20 years. He specialized in cardiac electrophysiology, interventional cardiology, and then the adult congenital heart disease. He is also a founder of Charles Corner Education Group. What's more, he's not only a good teacher, not only a good cardiologist, but he's a good singer, rocker, and the guitarist of the Renaissance rock band. So I think everyone is really excited to get the lecture. And without further ado, let's go straight into the webinar topic. Dr. Carlos Morales, please.
I appreciate the invitation to participate in a program that is part of the system of education for revolution and revolution for education. Thank you very much for the invitation. Before we get started, I would like to introduce myself. I'm a cardiologist in McAllen, Texas, and I've been a doctor for 44 years. I did my training at the Texas Heart Institute in Houston. And I'm 6 times board certified in cardiovascular diseases, interventional and structural cardiology, and internal medicine. And I founded Charlie's Corner in 2015. And this is the picture of me when I was 10 years old that I use in Charlie's Corner. I'm also a musician. I'm the lead singer and guitar player with the Renaissance Rockers, the best rock and roll band in the whole world, I want to think. But the most important title in my CV is being a grandfather. I have 2 granddaughters, Elena and Zoe, and that's basically what I'm most proud of. I would like to start by showing you a case that will hopefully start a discussion about how to take care of people with heart attacks in places that don't have a cath lab, which is basically a return to basics type of deal. I have no conflicts of interest. In 2014, a friend of mine texted me that her 30-year-old son was having chest pain. And she texted me his electrocardiogram, which, as you can see, it shows a ST elevation in the anterior and inferior leads, meaning that this patient probably has an occlusion in the left anterior descending coronary artery that is a wrap around the apex to be able to include the inferior wall. So I texted her back and I told her to bring her son to Doctor's Hospital at Renaissance right away. She said, there is a little problem. My son is in Guyana. So her son was not here. And then I realized that it would be very difficult for him to come here on time because Guyana is about 3,000 miles away from McAllen, as you can see there. So using my cell phone, I checked, and in 2014, there were only 2 hospitals in Georgetown, the Georgetown Public Hospital and the Joseph Mercy Hospital, and neither one of them had a cath lab. Furthermore, none of them had TPA, and only the Georgetown Public Hospital had a streptokinase. So I tried to manage an anterior myocardial infarction 3,000 miles away using just my cell phone. I talked to his doctor in Guyana, and I told him to give him intravenous streptokinase. I told him to start an IV heparin after giving the streptokinase. His chest pain went away in 30 minutes. His EKG normalized as well. He was kept in the hospital for 10 days, after which he was flown to Venezuela, which was the closest place with a cath lab there, where he had a cardiac catheterization. And his cardiac catheterization showed that his coronaries were fully open. That's the day when I realized that not all hospitals have a cath lab to take care of these problems. As a matter of fact, here in the United States, only 36% of all the hospitals have a cath lab, and not all of them, they have a staff and a program dedicated 24/7 to take care of people with heart attacks. In 2010, during the earthquake in Haiti, I volunteered to work there doing general medicine. And I realized that we have been spoiled because the medical facilities in other places are not like the ones that we have in the United States. For example, that building that you see there is not a latrine. It's a pharmacy. You can see the sign in the bottom. That's a pharmacy where people come to buy their medicines. And I really doubt that they would have TPA or any other expensive drugs in there. We definitely have been spoiled. This is the place where we work here in McAllen. This is Dr. Hospital Al Renaissance. This is the West Campus. This is the East Campus. This is the South Campus. And we have 19 cardiologists and a staff 100% dedicated to take care of people with acute MIs. Which leads me to believe that anybody can be a good cook when they have all the ingredients to their disposal. But we have to learn from the blues players. When you play blues, you have only 12 bars to make a song. And all the history of the blues in the world is based on those 12 bars. So you have to be extremely good in order to make something beautiful out of just 12 bars. And it's the same thing how we treat acute MIs. Let me spend some time to you to discuss how heart attacks happen. This is a picture that shows the evolution of the coronary plaques in a patient with atherosclerosis. It all started with foam cells to my left that actually you can only see microscopically. This usually starts when we are in our 20s, which evolves to fatty streaks, intermediate lesions, atheromas, fibrous plaque, to end with a complicated lesion of rupture that, as a volcano or a pimple, you can see that it breaks and it exposes the lipid content, forming a thrombus. Here in this pathological specimen, you can see to my left the cross-sectional view of a coronary artery with a plaque where in blue the fibrous cap has ruptured right at the junction, and the lipid core has become in contact with blood to form a thrombus marked by a T there. And to the right is the angiogram to show how a blood clot looks like. Which means that what acute coronary syndromes have in common is the presence of a thrombus. As you can see as you could see in the previous picture, no other lesion in the evolution of coronary plaques is associated with a thrombus. So thrombus, the presence of a thrombus, is the hallmark of acute coronary syndromes. So the thrombus can completely occlude the artery, like in this case, or only partially occlude the artery. A total occlusion looks like this. It completely occludes the artery, and there is not even room for a red blood cell to pass through. When you have a total occlusion of the artery, then you have an ST elevation myocardial infarction that is manifested, as the name says, by ST elevation. If you have only a partial occlusion, like in this case, where there is a thrombus, but there is still space for blood to flow through, then you have a non-ST elevation myocardial infarction that is manifested by ST depression. So you can use this knowledge backwards in order to make the diagnosis and try to decide whether the artery is completely occluded or partially occluded. If you have ST elevation, then you can say that the patient has a STEMI and the artery is completely occluded. If you have a patient with chest pain and ST depression, then you can say that the patient has a non-STEMI and the occlusion is only partial. I need to remind you that a myocardial infarction is defined as a typical rise and fall of troponins. Why is this important? It is important because the elevation of troponins indicates myocardial damage, which is also the hallmark of a myocardial infarction. But the patient must have, in addition to the typical rise and fall of troponins, one of the following: ischemic symptoms and EKG changes that indicate myocardial ischemia. We don't have, when we have a patient though with chest pain suggestive of a myocardial infarction, we do not have to wait for elevation of troponins to make the diagnosis. We can trust our clinical skills and claim that a patient has a myocardial infarction when the patient has chest pain at rest, because the mechanism of ischemia is not an increase in myocardial oxygen demand, but instead is due to a decrease in supply. The chest pain should last more than 20 minutes, and chest pain of new onset that limits activity is also a characteristic pain in acute coronary syndromes. This is the incidence of the different types of acute coronary syndromes. The ST elevation happens in only 1/3 of the cases, and the other 2 will happen in 2/3 of the cases. The prognosis is also different. The acute coronary syndrome that has the best prognosis is unstable angina, because there is no myocardial damage by definition. Non-ST elevation myocardial infarction in blue has a better prognosis than ST elevation myocardial infarction initially, because at the end of 180 days, the prognosis for either one is just the same. I'm going to spend some time with you to discuss how to treat ST elevation myocardial infarction in places where we do not have a cardiac catheterization. When you see in the emergency room or in your office or in your clinic or in the hospital that comes with a chest pain with the characteristics that I described before, these are the things that we have to do. We give the patient oxygen. We take care of the patient's pain by giving morphine, nitroglycerin, aspirin, ADP inhibitors, beta blockers if they are not contraindicated, heparin, and then we should reperfuse immediately, either with a stent when we work in a hospital with a cath lab, or using thrombolytics if we do not. The indications to use oxygen in a patient with the clinical suspicion of a myocardial infarction is if someone has a saturation less than 90%, or if a patient has shortness of breath or heart failure. We have to be aware that if a patient is normoxemic, there is no evidence of benefit by using oxygen. This was demonstrated in the DETOX-2 trial and the AVOID trials. As a matter of fact, there is some evidence that using oxygen in people who have normal oxygen saturation in the blood and they're not in failure or short of breath could be harmful. As a matter of fact, when people come with acute MIs and we treat them, we reperfuse the artery by whatever means. If the oxygen saturation is more than 90%, the first thing I recommend is to stop the oxygen. There are class 1 reasons to use nitroglycerin. We use sublingual nitroglycerin for chest pain to that particular dose. And if there is no response, which you want if a patient has a myocardial infarction, we recommend using intravenous nitroglycerin. We have to be aware when not to use nitroglycerin. We should not use nitroglycerin if the patient has a blood pressure less than 90, if a patient has a right ventricular infarct, or if a patient has used Viagra in the last 24 hours, or Cialis in the last 48 hours. Aspirin. Class 1 indication for aspirin is to use chewable aspirin, 325 milligrams. Unless the patient is already on aspirin, 81 milligrams, we continue the same dose. It's very important to check the patient's medications. And if the patient is taking non-steroidal anti-inflammatory drugs such as ibuprofen, meloxicam, sulindac, naproxen, we should discontinue these medications immediately because there is evidence that the use of these drugs increases mortality, reinfarction, and heart failure due to COX-2 selectivity. There are 3 ADP inhibitors that we could use in myocardial infarction. Clopidogrel, which is Plavix, prasugrel, which is Effient, and ticagrelor, which is Brilinta. All patients with ST elevation myocardial infarction should be treated with dual antiplatelet therapy, regardless of how or if the artery is reperfused. This was demonstrated in the CURE trial. So it doesn't matter if we treat the patient with thrombolytics. It doesn't matter if we treat the patient with stents. It doesn't matter if we decide to treat the patient conservatively without none of the above. The patient should be on dual antiplatelet therapy. Since our talk today is about how to treat myocardial infarction in people without a cath lab. That means that it's very likely that we will use thrombolytics. And I want you to be aware that if the artery is reperfused using thrombolytics, the only ADP inhibitor that we could use, that we should use, is clopidogrel, as opposed to what we do when we open the artery using stents. If we use a thrombolytic, we should not use ticagrelor or prasugrel, because a patient who is being on ticagrelor or prasugrel is a relative contraindication to use thrombolytics. This was demonstrated in the Clarity TIMI-28 trial published in the New England Journal in 2005. Another point that is important, that is different from other strategies, is what dose of clopidogrel are we going to use after thrombolytics? If we're dealing with a patient that is younger than 75, we use a 300 milligram loading dose. But if the patient is older than 75, we should not use a loading dose, and we should start just giving the patient 75 milligrams daily. These are the mechanisms why beta blockers in acute MI are beneficial. They decrease oxygen demand because beta blockers reduce heart rate, blood pressure, and contractility. They decrease the risk of ventricular fibrillation and decrease sudden cardiac death. Since beta blockers produce bradycardia, bradycardia prolongs diastole, and since coronary perfusion happens in diastole, coronary perfusion is improved. Beta blockers produce a reduction in remodeling. They improve left ventricular diastolic function. There is some evidence that beta blockers may slow the rate of progression of atherosclerosis in patients with or without MI, as demonstrated by intravascular ultrasound. Beta blockers inhibit platelet aggregation, since epinephrine is a determinant of a stimulant for platelet aggregation. And by any of these mechanisms, beta blockers can reduce the reperfusion injury. This is a graph that shows that independently if the patient has ST elevation myocardial infarction or non-ST elevation myocardial infarction, the use of beta blockers will definitely improve survival. These are the guidelines for beta blockers, and probably the most important thing is to remind you of the contraindications, the class 3 recommendations for beta blockers. Number one is when patients have an ST elevation myocardial infarction due to cocaine abuse. The mechanism is that cocaine releases epinephrine, and by blocking the beta receptors, the alpha receptors remain unblocked, and they are prone to produce ill effects. Patient is hypotensive, we should not use beta blockers. If the patient is in acute heart failure, we should not use beta blockers until that is taken care of. If someone has low cardiac output, if someone is at increased risk of cardiogenic shock, meaning people older than 70, blood pressure less than 120, heart rate higher, faster than 110, and delayed presentation after myocardial infarction. Or patients who have first degree AP block, second degree, or third degree high block, we should not use beta blockers. Or patients who have a history of asthma. The duration of treatment with the beta blockers post-MI has not been decided yet. It's not known what the optimal duration is, but we do know that the benefit may last for at least 3 years. And it is recommended that patients that presented in cardiogenic shock, heart failure, or chronic kidney disease should receive beta blockers for life. Anticoagulation in ST elevation myocardial infarction is rather simple. Class 1 is just to use unfractionated intravenous heparin, and the use of bilirubin is recommended if there is a prior history of heparin-induced thrombocytopenia. As I told you from the beginning, there are two ways how a patient that presents with a myocardial infarction should be reperfused. Independently of the method, if we use the balloon, we should open the artery in less than 90 minutes. And if we use thrombolytics, we should use it if in less than 30 minutes. The reason for that is that, as you can see here, in the MITI, EMIP, GC1, and ICIS-2 trials, the greatest reduction in mortality is seen when the strategy is applied in the first 2-3 hours. After that, there is still a reduction in mortality, but it's not as acute when used early on. And there are two trials that study the effect of reperfusion when it's done late. There's still a reduction in mortality, but not as much as in the first few hours. This is a curve that shows the increasing mortality with delays in reperfusion. This is using a balloon. If we open the artery using a balloon in 3 hours, in less than 90 minutes, then the mortality is only 3%. But if we wait 150 minutes, then the mortality increases to 7.4. So what it means is that we have to make a decision quick of how we're gonna fix the problem. If we use, this is what happens when we use fibrinolytics. Patient start with a myocardial infarction. Patient takes time to respond to the symptoms. Then we start the drug early on because it's easier to start a IV drug than to take the patient to the cath lab, but the flow is restored at the same time. The same thing happens with PCI when you use a stent. The difference is that the timing to make a decision will be longer, but the restoration of flow will happen at the same time. What we have to do is to shorten each one of these intervals so we can comply with a benefit by having a door to balloon time within 90 minutes and a door to needle time within 30 minutes. This is a comparison of all the trials, 23 randomized trials, comparing opening the artery with a stent in green versus thrombolytic therapy in red. Definitely PCI is superior in terms of reduction in death or non-fatal myocardial infarction in a reduction in hemorrhagic strokes. But then again, it doesn't serve any purpose if we don't have a cath lab. So we have to use what there is available to us. So how do you decide if you're going to treat the patient on site, drip the patient, or ship the patient to a different place? And the decision is based in the following formula. If the door to balloon time minus door to needle time is less than 1 hour, you transfer the patient to a place that has a cath lab. If the door to balloon time minus door to needle time is more than 1 hour, then you use thrombolytics. There are different types of thrombolytics. The first generation is the streptokinase, second generation is alteplase, and the third generation is reteplase or 10K. This is the dose that we have to remember. If we use a streptokinase, the dose is 1.5 million units in 1 hour. There's one thing that I want you to be careful about. If we choose a streptokinase, we should not use heparin at the same time. We should wait until the infusion of streptokinase is finished before we start intravenous heparin. All the other thrombolytics, alteplase, reteplase, or tenecteplase, which we could use heparin at the same time. I want you to be aware that there is a price to pay for using thrombolytics. There is a risk of bleeding. This has been demonstrated on those 3 big trials, or more than 100,000 patients. And one of them, if you do many cases, you will find a patient that will have an intracranial bleed. And then you can see the comparison versus streptokinase versus TPA. There seems to be at least the advantage for streptokinase to produce less intracranial bleed, as long as you don't use heparin at the same time. You have to be familiar with the contraindications of thrombolytic drugs. The absolute contraindications is the history of hemorrhagic stroke ever, a history of non-hemorrhagic stroke in the previous year, the presence of an intracranial tumor, the presence of a dissecting aneurysm, or obviously active bleeding. Relative contraindications for thrombolytic drugs are, if the patient is hypertensive, we have to control the blood pressure first. If the patient has been on Coumadin and the INR is more than 2, recent trauma that includes starting a central line in a vessel that cannot be compressed, i.e. subclavian, surgery in the past 3 weeks, puncture of a non-compressible vessel, recent internal bleeding, pregnancy, and active peptic ulcer. This is one of the early trials. This is the ISIS-2 trial that enrolled about 17,000 patients to receive aspirin, streptokinase, none of the above, or both of them. And then you can see here that the combination of a streptokinase and aspirin was far superior to giving the patient nothing. So yes, there is a risk to use a streptokinase, but if that's all you have, that's what you need to use, because a streptokinase and aspirin is better than nothing. When you have a STEMI, there's a possibility that we may have complications. Some of the electrical complications of a myocardial infarction is sudden death. The risk of sudden death is highest during and immediately after an infarction, and then declines over the following days and months. And 1/4 of arrhythmic deaths will happen in the first 3 months, and 1/2 within the first year after a myocardial infarction. The incidence of sudden cardiac death eventually stabilizes at a level compared to individuals who have never had a myocardial infarction. This is the indication for AICD implantation after STEMIs. And the point that I'm trying to make here is that there is really no indication for patients to have implantation of a defibrillator in the acute phase of a myocardial infarction, regardless of the presence or absence of ventricular tachycardia or ventricular fibrillation, because those can be ischemic. The recommendation is to wait at least 40 days after after STEMI, or more than 3 months if a patient was revascularized. That will give you time to transfer the patient to a center that has reduced LV function to have a defibrillator implanted. These are the indications for temporary pacing in ST elevation myocardial infarction. You do not need a cath lab for this. You could use a transcutaneous pacemaker, or you could implant a balloon tipped pacemaker using only fluoroscopy. These are the indications for temporary pacing, complete heart block, alternating right and left bundle branch block, right bundle branch block with alternating with left anterior hemiblock or left posterior hemiblock. A new or age indeterminate trifascicular block, patient who is in asystole, which is very seldom that is going to work, or symptomatic bradycardia of any etiology. If hypotension is present and the arrhythmia is not responsive to atropine, or the presence of a Mobitz type 2 second degree AV block is another indication for temporary pacing. There are three mechanical complications of myocardial infarction. To my left is ventricular septal rupture. In the middle is a rupture of the free wall with tamponade. And to my right is acute mitral regurgitation due to rupture of the papillary muscle. If this happens, regardless of where you are in a place with or without a cath lab, if you have one of these complications, the mortality is exceedingly high, and your patient is very unlikely that it will survive. What is important is to understand that there is a relationship between the ejection fraction that the patient ends up with and mortality. This is from GISI-2 trial, and then you can see the mortality is lower as the ejection fraction is higher. There is an inverse relationship between ejection fraction and mortality. That's the reason why time is muscle, and we like to preserve ventricular function by opening one artery by whatever means become available to us. Patients may come in cardiogenic shock, which is defined as a clinical condition of inadequate tissue perfusion due to cardiac dysfunction, and is diagnosed by persistent hypotension, and the management is norepinephrine or Levophed. This is the drug of choice. It is important to realize that if a patient comes with a myocardial infarction and is hypotensive, these patients should have a right-sided precordial leads to make the diagnosis of right ventricular extension. And since these guys are preload dependent, the first thing to do for this patient is to use a lot of fluids, usually normal saline. And after the myocardial infarction, don't forget A, B, C, D, E, and F. A is for ACE inhibitor, or aspirin, indefinitely, and ADP inhibitors. B, beta blockers. C, ACE inhibitors if the ejection fraction is less than 40%. D is diet and statins. We use the most potent statin that there is available to the highest dose. This is not time to titrate the dose. From the very beginning, even without measuring lipid levels, we should use the statin that we have available to the maximal dose possible. Exercise is definitely necessary, and F is for forget about smoking ever again. I'm going to finish my presentation by presenting you a case that is not uncommon in my part of the world, since we live about 15 minutes from the Mexican border. This is a 76-year-old man from Reynosa who has severe retrosternal chest pain that he described as oppressive, radiated to the left arm, and associated with diaphoresis and shortness of breath. So the The symptoms are typical of a myocardial infarction. So after 2 hours of symptoms, he was taken to a small hospital in Reynosa that doesn't have a cath lab. The patient has a history of hypertension and has smoked 1 pack of cigarettes per day for 50 years. He suffered an ischemic stroke a year ago. He denies diabetes. These are his vital signs. His blood pressure is okay. The patient has a heart rate of 96, and he is obese with a BMI of 32. His jugular veins were flat, and his lungs were clear, and the patient had an S4. Alteplase was not available, but they had streptokinase. The estimated door to balloon is 2 hours, and the estimated door to needle is 30 minutes. This is this patient's electrocardiogram that shows a first degree AV block with a prolonged PR. And you can see ST elevation in the anterior lead, suggestive of an acute anterior wall myocardial infarction. So, which one of the following statements is correct? The patient will do better if transferred to a hospital with a cath lab. Number 2, start patient on intravenous heparin. Number 3, streptokinase. Number 4, ticagrelor. Number 5, prasugrel. Number 6, clopidogrel, which is Plavix, 600 milligrams, followed by 75 milligrams PO daily. So the question is, which one of the following statements is correct? And the answer is streptokinase. And the reason for that is the following. The patient should be treated on site because the door to balloon time minus door to needle time is more than 1 hour. As a matter of fact, in this case, it was 1.5 hours, meaning that there is not enough time to send him from Reynosa to cross the bridge to come to the United States for a balloon. So the patient should be treated on site with thrombolytics. Number 2 is not correct because we are planning to use streptokinase, the only thrombolytic that they have available, and heparin should not be used before streptokinase. It should be used after streptokinase. Number 3 is the correct answer based on the ISIS-2 trial that demonstrated, as I showed you, that streptokinase and aspirin definitely reduces mortality as compared to only aspirin or doing nothing. Ticagrelor and prasugrel are relative contraindications if we use a streptokinase. And number 6 is not correct either because the patient is older than 75. And if in patients who receive thrombolytics that are older than 75, they should not be loaded and should be started on the Plavix or clopidogrel 75 milligrams PO daily. And once again, I appreciate the invitation to and the honor to express my thoughts with you. I have worked in all sorts of medical systems. I've done volunteer work in other places. So I'm familiar how to take care of these problems, even if we are being spoiled by having the best technology. And I wish you the best, and I support your cause, and I agree with Education for Revolution and Revolution for Education. And feel free to send any questions if you have any.